Thank you, and welcome to this second session. This one is on the principle of care and support being person-centered, coordinated, and empowering. I'm really looking forward to this. I know I went for about a decade without participating in any way in decisions about my own healthcare, and in fact, I needed to have power in terms of self-management and then leading my own care before I could do anything collectively. So we need to hear about this, and it's great that it's relatively early in our session. Without further waffle from me, I'm going to hand over first of all to Natalie Kusa, who is the program lead for Wellbeing Our Way National Voices. Over to you, Natalie.
Hi, Ali. Thank you very much for that. So good afternoon, everybody, and welcome to the third session of the People's Transformathon. We're really thrilled to be with you today, so thank you for inviting us. I will today be joined by Lindsay Oliver, who is the National Director at the Year of Care Partnerships, Lynne Craven, who is not only an expert by experience, but has also partnered with National Voices throughout the planning of today's session, Alf Collins from NHS England, and Chris Dabbs from Unlimited Potential. So today we will be focusing on Principle 1 of the 6 principles, care and support planning, which is person-centered, personalised, coordinated and empowering. We'll be exploring what person-centered care and support could look like within the context of today's health and care system, and offering an alternative understanding of the system. So as Alison was explaining just previously, we're going to be talking today about a system which may be in stark contrast to most people's experiences of today's system, one which includes people, their families, carers and communities as being integral to the health and care system and a central part of that system, rather than as on the edges waiting to be invited in or as passive recipients of care. So many of you might have seen the graphic that's hopefully showing on your screens at the moment. What this shows, so the purple wavy line going through the middle of the graphic, shows that the person is spending, so this is a person living with one long-term condition, 8,757 hours every year managing their condition or disability. And on average, the blue lines going through showing the episodic consultations, a person spends only 3 to 7 hours with their clinical team. Today, roughly 1 in 4 of us lives with a long-term condition. And as you can see from the blue lines, the time that people spend with their clinicians doesn't necessarily fit in with the time that people want to spend with their clinicians. So you can see the ups and downs of life shown by the purple wiggly line, and you can see that the consultations are pretty arbitrary, so they're consultations that fit in with the system. So it may be somebody's annual review, or you know, a consultation that is at a time convenient for their primary care practice. So if we fast forward to 2018, by this time we're expecting 2.9 million of us to be living with 3 or more health conditions. And really all we wanted to show from this graphic, it's not a scientific graphic, but what it does show is that the more conditions that somebody is living with, the more chaotic their care and intervention may get. And it leaves the person needing to manage and coordinate their clinical interventions alongside managing their health conditions. But there is another way. So this graphic has been taken from Realising the Value. You can see this report on Nesta's website, and it was published just a couple of weeks ago. So what this shows then is quite a nice outline for today's session. So if we look in the orange boxes where we can see care and support planning, Lindsay Oliver is going to be talking us through what care and support planning is, how it works, how it can help people to manage their conditions. We'll then move on to the centre of the system, where Lynne Craven and Alf Collins will be considering what self-management actually means in practice for people. And they'll also be considering how, when we understand what self-management means fundamentally, we can better understand how to tailor support and how to work with people effectively. And then finally, but by no means least, if we move over to the right of the slide to the purple box, Chris Dabbs is going to be introducing a couple of projects called Tech and Tea and Dudley Does It. And he's going to be explaining how using a truly asset-based approach can underpin and fundamentally change the way that we support people to take control and enjoy control over their lives. Finally, if I'm good at my chairing, there'll be 10 minutes left for questions at the end of this session. So please do join in the conversation. You can either type into your text box on the right, or you can use the hashtag CoPro16 on Twitter. So without further ado, I'd like to pass you over to Lindsay Oliver from Year of Care Partnerships, who will be introducing care and support planning.
Thank you, Natalie. So yes, I'm going to focus on talking about care and support planning. I'm going to use a couple of case studies of some general practices who have implemented care and support planning for their entire long-term condition population. And if you want to have a look at those case studies, you can have a look at them on the Year of Care website. But just to go back to the graphic that Natalie has looked at, and to refresh our memory about the bit that we're looking at. From the perspective of an individual, they spend very little time with a healthcare professional or social care professional, and they spend most of their time managing their own health through self-management. So in this session, I really want to focus on the care and support planning, which happens in those sort of regular bars, those regular orange bars, to think about how you can implement a process which creates the opportunity for people to have a more meaningful conversation, including identifying how the person may access support to help them live with their long-term condition. So this diagram here, it shows care and support planning as a cyclical, ongoing process with a number of stages which are very generic and can be applied to all sorts of different situations. It starts by taking a step back from the conversation and thinking about what it is that an individual needs to have to be prepared to take part in a collaborative conversation. And it makes sure that the individual has this information ahead of their care and support planning conversation and has the time to reflect upon it to enable a better conversation to take place. The conversation can then take place based on what matters to the person and is now about forward planning rather than thinking through or just rather than checking things, doing assessments or sharing information. It also acknowledges that different people might have different kinds of support that they need, and part of the process is about identifying that. So from a Year of Care point of view, we work with lots of general practices, many of whom are trying to implement this process as a generic and usual way of working instead of the usual annual review process, which often just feels like a tick box process of disease monitoring. These practices have implemented a single care and support planning process for people as individuals, no matter how many different conditions they have. And in order to achieve that and make it happen, they've had to change both the processes and how things happen within the practice, but also the very nature of the conversations of care and support planning. And this is very much about working with people rather than doing things to them. So in terms of the care and support planning process, practices have taken what would have been an annual review and created a two-step process which has a number of benefits from the point of view of both the practice and the individual. The first appointment, so the information gathering appointment, is used to ensure that all the medical tests, assessments, etc. are performed at a single review instead of over a series of appointments across the year. The individual is then sent their own information, i.e. they're prepared, which might include test results, agenda setting prompts, or places to write questions down that people want to be able to ask. They're invited then to their care planning conversation about a week later, having had time to digest and think things through, and are able to then take more of a part in that conversation and make more effective decisions, because there's less focus on sharing information and much more on working things through with people, trying to understand what things mean, take stock, discuss options, and develop an agreed and shared plan between the professional and the person with a long-term condition. From a practice point of view, it can really sort of save time in terms of appointments, because you're actually organising and doing things in a more systematic way. It uses skill mix better, and of course from a professional point of view, it actually is a much more rewarding way to work. It feels a lot more like doing what you actually went into your professional vocation to do. But the most important thing really is to think about this from the perspective of people who live with long-term conditions. And I'm going to give you some feedback that we've had from some people who've been through care and support planning in some local practices. Firstly, about the preparation phase of care and support planning and what it's like to receive that, but also about the value and usefulness of the conversation that people then go on to have. So from a preparation point of view, people say that this process gives them time to think about things, and it allows them to look at information at the pace that they want to, so that they can take things in, digest them, and find out and think about what they want to talk about. People have talked about the fact that they can see what's happening with their results and their condition and know where they're up to, and that it's so much better than being told that nothing needs to happen because everything's okay, or that it's not okay. And in terms of the conversation, people talk about the fact it saves a lot of time, it helps and makes it much easier to actually raise issues that people are actually worried about, and talk about the concerns that they have. And of course there are places to write things down that you really are worried about having to discuss if you want to. In terms of the actual conversation, this also depends on the behaviour of the healthcare professional and their attitudes and skills in having these conversations. But people have fed back that they felt for the first time professionals were actually interested in their perspective and what they had to say, and that they were having a proper conversation rather than having everything redirected through a computer, and being looked at almost as like a checklist of things that have to be done. And that has given them a space to actually talk about what was important to them. People talked about being able to ask questions instead of constantly being asked questions to fill in templates. They also said that it was much easier to talk about things when they knew what was happening rather than being kept in the dark, which is how the old system feels. And for many people what it meant was that they could actually talk about plans or solutions to the issues that they're really facing rather than go out of the door with a prescription. And that for many people, having the actual conversation was really very therapeutic in itself. So there seems to be an awful lot of value in working in this way, although there is an awful lot of work to be done to make it happen. And from the point of view of care and support planning, out of those conversations becomes individual actions, some of which will obviously be things like people choosing to do different things to manage their own health. But what we found through our programme is that people want a range of different sort of levels of support, and that care and support planning is a gateway to that support and is a means of connecting people to the support that they need, accepting that for some people some element of social prescribing may be useful to enable them to make that link and to make that connection. But overall, working in this way is systematic. It means that people get much more involved in the decisions and they have much more information in order to be able to do that. And the discussions are about what matters to the person, and it gives a forum to really have a proper discussion around what people want to do to look after their health, and what support there is out there to enable them to be able to look after their health. So I think at this point I'm actually passing over to Lynne, is that right?
Thanks for that, Lindsay. You've sparked, can you hear me?
Yes.
Yeah, fantastic. You've sparked a lot of conversation there, Lindsay, both on Twitter and in the chat box. So we will move over to Lynne and Alf in just a second, but I just wanted to give a little bit of an overview of the kinds of things that people are talking about, and then maybe we can pick it up in more detail at the end.
Yes.
So on Twitter, the conversation is pretty dominantly about acknowledging the assets of patients and patients' strengths. And interestingly, in the text box, it's the same theme but from the opposite side. So we've had Alison sharing her really terrible experience of sitting outside a room while professionals were sitting inside the room discussing her care plan. We've had, no, this is not what you're talking about in any way. We've had Mandy sharing about how she's not included in her son's NDTs, and Christine and others sharing that they've never had an invitation to be involved in care planning. And I think what's really kind of stark, the comparison, Lindsay, about your experience of care and support planning and the care and support planning process that Year of Care develops in partnership with primary care settings, is that it completely flips this on its head, doesn't it? And it really is a way of developing partnerships between people and their clinical teams.
Absolutely. No care plan can be developed without the person being in the room to develop it. The whole concept of this is that it's about working with people to work out what works for them. So no MDT team, no group of people should be making a decision about a care plan on behalf of people. People should be making their care plans through collaborative care and support planning conversations.
Fantastic. Thank you, Lindsay. If you're okay to hang around until the end of the session, maybe people can direct questions directly to you. Thanks, Lindsay. So would you mind passing the presentable over to Lynne and Alf, please? Or Lynne, on behalf of Lynne and Alf.
Hi. Thank you.
Thanks, Lynne.
Thank you. So I'm ready to go. I'm going to... Is that okay? Is everybody hearing me?
I can, Lynne.
Okay.
Yes, fine.
So I'm going to...
Loud and clear, Lynne.
Great. I'm going to spend a few minutes explaining what self-management means to me, and also think about... I don't know if I can move the slides on, though. Oh, yeah. What self-management means to me. I also want to differentiate it between... the differentiation between self-care and self-management, because I think they're very confused, and I think they can be very confusing, and both terms seem to be used interchangeably. So first of all, for me, self-care is about keeping myself healthy by following those public health messages like eating 5 a day, moving more, not smoking, taking alcohol in moderation. And it's a choice. It's a choice that people make to live healthy lives. Whereas self-management is not a choice for me. It's something that I have to do because I live with MS and I have to manage the impact that MS has on my life. I don't make a choice about self-management. It's what I need to do to live with MS. So it's what everybody needs to do if they've got a long-term health condition. And as Lindsay showed in her slide, and Natalie, life is a bit wavy. It's a wavy line sometimes. The way I describe it, I do not care for the MS, but I live with it. But I do manage the impact it has on my life, and often, as you saw through that wavy line slide, often on my own. And I'm going to describe self-management using the biopsychosocial model of health. Let me see. So the first slide, the medical bit, the biological bit, is about having a useful understanding of my condition and how they impact on my life. So it could be things like taking medication as agreed with the healthcare team, following the advice from the physio, working in partnership, and preparing for appointments. And if I had a care plan, I would certainly have prepared for it, but I don't. It's about the green emotional domain, knowing that how I feel will impact on my condition, and also the condition affects how I feel. So it's really complicated, and big ones for me are frustration and stress. my condition, having MS, leads to frustration, and that in its turn leads to stress, and that makes things a lot worse. So it's about recognising that that link is really important, and to help me, I use a lot of mindfulness to sort of calm that emotional circle down. And then the social circle is about being willing and able to adapt to the changes that living with MS has brought in my life. And so it's, for example, using a shower stool to make that easier for me, and also being prepared to use a wheelchair when I'm out shopping. And it's also accepting the changes that have come in my life, recognising that I can no longer yomp up the fells in the Lake District, which is what I used to like doing, and I can't do anymore. So I've got to find some other things that bring enjoyment and joy to my life. So life with a long-term condition can be chaotic, and it's really hard because you've got all of those domains to think about. And what I like to do is think about self-management as optimal, and I have to think about all three things. And when I'm balanced and making all those changes in my life, then I consider myself to be self-managing optimally. And then don't forget that there is everyday life to contend with. I have to pay bills, look after my children, do some work when I get them, etc. So self-management has to happen within your everyday life. And I've included self-care in that outer circle, because I think it's important to recognise that when you live with a long-term condition, you're not just self-managing, but you are also self-caring if you choose to. Self-management is hard work. If I'm managing optimally, I don't see myself as a victim, as somebody who's suffering with MS, and I don't feel that I'm defined by my condition. I'm just managing it and living with it quite well. And Alf, are you ready now to talk? Bearing all that in mind? Right,
I am,
Lynne.
Thank you.
There you are.
So, thanks, Lynne. So just listening to what you've just said, Lynne, what I'm hearing is this isn't just about managing your medical condition. You didn't actually talk about that so much. You talked about managing life with your condition. You talked about living with. You talked a lot about the impact of your condition on your emotional world and on the way you live your life, both at home and outside the home. And what I don't think we do enough of is listen to people's stories and listen to their stories about the impact and the complexity and the juggle. It's interesting, those slides, as those three domains came together, Lynne, the medical, the social and the emotional, as they came together with that beautiful balance, which, you know, it's a precarious balance sometimes, when they do come together, that sweet spot in the middle, that must feel amazing.
It does.
And I think sorry, Lynne, It
does.
And I think one of the things we do in healthcare is I don't think we really support people with that balance. We focus rather too much on the medical. We don't talk enough about, we don't listen enough about the way that conditions impact on people's well-being. And of course, you know, if our emotional world is less well controlled, less under our control, then of course managing the conditions themselves becomes more complex. So we just don't do enough to support people to hear about the impact and then support them to manage the impact of their conditions. And that for me is a big missing piece of the jigsaw right now. We're far too medical. Of course the medical piece is really important.
Yeah.
But we just need to listen more and provide more support with regard to the impact. Lynne, I don't know what your thoughts are about that.
agree. The make this circle is actually the easy. It's not difficult taking your medication and following advice, especially if you've just told you. It is often the emotional bit that's the hardest bit, and that support doesn't come easily from the system and from health professionals that you meet. Hi, I'm back.
You talked about the professionals that you meet, and then we lost it. So
yeah, and I was also about getting some knowledge, skills, and confidence to self-manage.
Yeah. So I think Lynne and I, between us, think there's quite a big piece of the jigsaw missing here, supporting people to develop that knowledge, skills, and confidence, and supporting people to talk about the impact, to support them to understand that they are themselves resourceful and can manage that impact. And with our support, the support of both the system and the communities within which they live, that impact can be minimalised. Shall we hand back to Natalie now, Lynne?
Yes.
Let's do that. Natalie, back to you.
I've got to pass that ball.
Thank you both.
Can somebody pass the ball to Natalie?
Can you actually pass the ball directly to Chris, if that's okay? I don't need it. It can go directly to Chris. Thank you. Thank you so much, Lynne and Alf. Overwhelmingly in the chat box and on Twitter, there was conversation about how fantastic it is to hear from somebody who's living with long-term conditions every single day about the difference between self-management, self-care, and what optimal self-management actually means. Lots of questions about jargon, essentially. So what does person-centered care actually mean? Can we talk about this in plain English? And I think, Lynne, that you've really helped us out with that. Lots of people saying that they really benefited from you going into detail about what you see as the difference between self-care and self-management. And then, as Alf says, when you brought those three balls together to show the optimal bit in the middle, it was really clear to people exactly what that might mean. It's also a fantastic segue into Chris's session. Chris is going to be thinking about a similar theme, but much more from the perspective of how can we work with communities to enable them to build on their strengths in order that people can live well with their long-term conditions. So Chris, over to you if that's okay.
Okay, thank you. Thank you. So in the next 10 minutes, we're hopefully just going to cover what asset-based working is and to give you a couple of examples of what it means in practice. So that challenge about lots of jargon and asset-based approaches is another piece of jargon, but essentially what it means is ways of working that build on or connect existing assets and what I prefer to call strengths. And that avoids the idea that assets are just physical things like buildings and so on. And it's as much about the strengths that people have themselves. In a health and well-being context, it actually changes the question that we're trying to ask. The question from an asset-based approach is what makes us healthy, whereas from what I would call a needs-based or deficit-based approach, it's about what makes us ill or what can help us deal with illness. So the asset-based approach I'm going to talk about is much more focused on health and well-being rather than illness. So assets or strengths, what are they? So they can be a range of things. So they can be practical skills, the capacity and knowledge of local people. So literally just what local people can do, what they know, what they have. And often that contrasts with their experience of systems like health and social care, but also other public services, where often people are defined by what they can't do, what they don't know, and what they don't have. Assets are about what people do know, what they can do, and what they do have. It's also about local people's passions and interests and the things that give them energy for change. So it's important to try and find within people and help them draw it out about what will get them motivated, what gets them up in the morning. Particularly important are the networks and connections between people, that in the jargon is known as social capital. So what creates friendships and neighbourliness? And often we find in asset-based working that that's often the most valuable thing that people can create themselves, is making new social connections and new friends. Beyond that, in a wider sense, assets can also be about local voluntary associations, so that could be community groups, voluntary organisations, social networks, and so on. But it can go beyond that to the resources that organisations in all sectors have that are made available to support a community. So that could be indeed what public services do, and particularly the resources that they make available to support a community. Equally about what the third sector does, but also what private sector organisations do in terms of enabling local people and local communities to do things. So it's a very broad definition that we're working with. And then finally, there are the physical and economic resources that any place or neighbourhood has that can be used to enhance well-being. And I think the challenge with the use of the word assets is that often people think it's only that last element that we're really talking about. So it's why I prefer to talk about a strengths-based approach rather than an asset-based approach. And then we realise that most of this stuff is about people rather than physical things. So 5 basic principles to asset-based working. First off, it is asset-based, so it's about valuing the assets that and strengths that people have and the links and associations that they benefit from. Secondly, it's about being community-based, so it's working in the space where networks come together and where shared interests are negotiated and acting on. And in practice, certainly from my experience, that's generally about going to where people are. It's not waiting for them to come to you. Thirdly, and perhaps crucially, it's about relationships. It's about creating the conditions where people can act in a mutual way, where they can share things, where they can reciprocate. So if one person gives something, they get something back from the other person. And it's also about creating solidarity between people. So they feel that they've got a greater degree of power and control over their lives. Which leads on to the 4th principle, which is this is person-led. So this is about individuals and communities discovering their own potential and about them taking control. It's not about delivering solutions to them. It's not about seeing them in a deficit way and the rest of us then charge in pretending we've got all the answers. And then at some point we tend to wander away again and leave them sometimes in a worse state. Asset-based working is about helping people discover what they already have and to help them realize the potential that they've already got. And finally, the final principle is it's about promoting social justice and equality. So it's enabling everybody to have access to what assets they need in order to flourish in their lives. So you can probably already tell from some of the language that I'm using that in a sense this is political with a small p. This is about shifting power and it's about shifting control, and it's not about, on the whole, about just delivering more services to people. It's about people taking control and doing stuff in the way that suits them. So a couple of examples from Salford, where my organisation is based. The first one is called Tech and Tea. This is one part of the community assets work stream within the Salford Together Integrated Care Programme. In essence, Tech and Tea is a 5-week low-level digital skills project to help older people improve their access to information and to develop IT skills. Often we're working with older people who've never used IT before, or maybe have had a tablet bought for them for Christmas, but have been too worried to open the box or switch the tablet on. So Tech and Tea, the approach is to try and engage people in looking at the benefits of technology for neighbourhood activity, to reduce social isolation and to improve well-being. It's run within community venues, so it's going to where people already are, where they feel comfortable, using both tutors and volunteers. And within this approach, we've identified a range of teenagers for whom obviously digital and tech is quite normal, and then being trained up not to show people how to use the technology, but to find out what are people already interested in, and then show them how technology can expand that interest and give them new links. So that could be talking to your grandchild in New Zealand, or finding out about your local community history, or whatever other topic that people are interested in, and then enabling them to learn how to use technology around what's of interest to them. Because otherwise, in essence, technology is just some fairly boring pieces of plastic and metal. At the start, we found that 70% of the older people who've engaged in this process had no prior experience of doing basic computer tasks. And after 5 weeks of using this asset-based approach, working with each other and with young people, 90% of people who engaged felt that they could complete those basic computer tasks, which means that they've then got the basic access to the internet and to communication. And many of the things which many agencies and services almost expect local people to have now, but it's doing it in a way that's social, and it's doing it in a way which helps people to create both friendships within their own age group, but also making new connections across the generations. The other example is a program that my organization's been running, which is now called Dadly Does It, originally called Salford Dads. And this is about focusing on the well-being of fathers and to explore the impact of good fathering on the well-being of children. We've used an approach which is strengths-based, which is called positive deviance, which is basically a way of identifying those people in a community who are already seen to be doing better than their peers, even though they've got only the same resources. And our approach in terms of working with dads has been produced with a group which became known as the Council of Dads. With men in a very low income community in this case, we worked alongside them to create male friendly spaces, which in itself was important because the men told us that they found all children's services very female friendly, but by definition or not very friendly to men on the whole. And it was to create male friendly spaces where positive role models amongst the fathers can talk openly to each other and also try out fun dad and child activities that can enable bonding. And that element of fun, of doing things together, and just learning by watching. So there's no training, there's no teaching, there's no coaching. It's just bringing people together and then watching each other and effectively just copying the positive things that they see. The benefits that come out of that approach for the fathers, they've talked about having a more positive identity, about having greater social connection, and particularly being able to talk in an emotional way, but still feeling that you're doing it in a masculine style. And also for them, it was about moving towards or into meaningful employment. So virtually all the men that we've been working with have been out of work for between 4 and 20 years, all with some form of experience of mental health issues and so on. For children, when we've sought their feedback, they've described much better relationships with their fathers. They see them as people to do stuff with. And also the children were able to articulate the improvements in their own behaviour and well-being. And effectively between the dads and the kids, they realised that previously fathers were projecting their problems onto their children. And what they're now doing is to project their strengths and their development onto their children with the following impact. Perhaps the most interesting element, though, is when we asked mothers about the impact of the work that we've been doing. And they described greater shared parenting, because often, particularly the mums and dads, had split when the children were still quite young. It improved family relationships. There were more positive things to talk about. Dad was seen as having a more positive role within the family as well as with the children. And for some of the women, it created just a generally more positive view of men. We've had some women who've never had a positive view of men in their lives before, who are now seeing men doing sensitive stuff and listening and doing positive things with children. From a quantitative approach, we've had a social return on investment done, which suggests that for every £1 that's gone into the work with fathers, for children's services alone, it's saved in the region of £3 for every £1 that's gone in. And in terms of well-being value, it's somewhere between £13 and £19 well-being value for the fathers. Put in a more realistic sense, for our dads, that means that they would have to be earning in the region of £65,000 a year in order to get the same degree of well-being, even though most of them are living on welfare benefits in some sense or other. So just to end with a couple of views from the local people that we've been working with to tell you a little bit more about the impact of that work with fathers. First off, a comment from one of the dads, excuse the language, he says it's great because it's not another bloody service. Most of the dads that we work with have been through numerous services over the years, which have cost an awful lot of money. And they're not critical of the people who work within those services, but there's a point that they've got to when they don't need another service. What they want to do is to get on with life. And this is what the approach is allowing them to do. And hopefully, and you'll see from the second quote there, we're beginning to pass a message on. So instead of having what we have in many of our communities where we've got multi-generational poverty and negative behaviours being passed on, we've now got positive behaviours being passed on, where hopefully we've got teenage boys now, for example, who think that when they become fathers, they want to start behaving in the same way and bring their own kids to Salford dads. And in that way, we're hoping that we can start to shift the behaviour within a whole community, rather than just working with people one by one, to the point where the aim ultimately for everything that we do is that community gets to the point where they tell us to get lost because they don't need us anymore. Thank you.
Sorry, there we are. Thanks so much for that, Chris. The chat box was just full of huge praise for the fantastic work that you're doing, and people really helpfully sharing resources to other kinds of work that are based in an asset-based approach. I'm really mindful of time. Lynne, I was wondering if I might be able to pass over to you to close. We've had one question that's come up time and time again on Twitter and a couple of times in the chat box throughout this session. The question is, what does person-centered care, coordinated and empowering, mean in plain English? Thank you to Bill Russell for tweeting this. And I thought, Lynne, if you don't mind reflecting on this very, very briefly, we've got about 1 minute until we need to finish. Might be a nice way of closing the session.
That's no challenge at all, then. 1 minute. Yes, this is last word to Lynne on this.
Over to you, Lynne.
Okay. What does person-centered coordinated care mean to me? Well, there we are. Everybody's talking about it. Nobody's doing it. I always say I am at the centre of my care because it is me that coordinates it. It's not the system. This is why I would really like a care and support plan, as a collaborative care and support plan, because I often feel that person-centred coordinated care is surely care that's done in partnership, and it's just not happening. It feels like it's a buzzword, and I do not know what it means because I don't really know that I get it. I'd like to, but I don't. So I'm not sure I'm the one to answer that, really. Except I do know that it should be good.
But what more powerful call to action can there be in close to the session? So that's us out of time. Thank you very much to everybody that took part, both on the direct panel and also through the chat box and Twitter. And thank you so much to the People's Transformathon for having us today.
Fantastic. Thank you so much. That's been a fantastic session. Thank you so much for that. And we need to keep the Get Lynne a Care Plan campaign. We need to make that national. And do keep us informed if you eventually do get a care plan. We'd love to hear about it. We're just going to close this session now, and so that we can change things around for the next session, which is going to be fantastic, all about well, it's the comrades who really get it about co-production, and they're now looking at me in horror at what I'm across the room. So don't go away. We'll be back with you in 5-10 minutes or so. Thank you very much.